efficacy of cyclophosphamide on recalcitrant Vogt-Koyanagi-Harada syndrome disease. The author is Dr. Naveen Keshav.
Good afternoon to one and all present here. My study is on efficacy of the cyclophosphamide on recalcitrant Vogt-Koyanagi-Harada disease. So, Vogt-Koyanagi-Harada disease is a chronic bilateral granulomatous synovitis with exudative retinal detachment and extraocular manifestations. So, it is a T helper cell mediated immune response to the tyrosinase antigens in the melanocytes. So, the aim of therapy is to suppress the inflammation in the acute stage and prevent the progression to the chronic stage, and in reducing the sequelae by the use of systemic steroids and immunosuppressive agents. So, in the previous studies, immunosuppressive agents that were used for VKH were methotrexate, mycophenolate mofetil, azathioprine, cyclosporin A. Here in this study, we shared our experience with cyclophosphamide for recalcitrant VKH. So, cyclophosphamide, the mechanism of action, it's an alkylating agent which targets the DNA bases, cross-linking them to cause cytotoxic effects on the T and B cells. It is Perez et al. Found to be beneficial in recalcitrant non-infectious uveitis. So, it's a retrospective study of 199 patients with VKH who visited in the study period. 8 patients were started on oral cyclophosphamide who were found to be refractory to other immunosuppressive agents. The end point of the treatment being control of inflammation and improved visual acuity. So, recurrence of inflammation were recorded during the follow-up. So, we used the revised international diagnostic criteria for VKH diagnosis, and the indication for starting cyclophosphamide therapy were treatment failure to other immunosuppressive therapy, steroid intolerance, and intolerance to previous immunosuppressant. So, the dosage of cyclophosphamide we used was 100 milligrams per day of oral cyclophosphamide, that is 2 milligrams per kg body weight, for a minimum of 6 months until inflammatory control was achieved, after which it was reduced to 50 milligrams per day for 3 months. So, total of 8 patients, all had bilateral VKH, the mean age of presentation being 43.37 years, the median duration of uveitis being for 9 years. Male to female ratio was 1:3. The acute anterior uveitis was found in 25% of the cases at the initial presentation, and 75% of the cases had exudative retinal detachment as the initial presentation. So, the previously used immunosuppressive agents were methotrexate in 3 patients, mycophenolate mofetil in 2 patients, and 2 patients were started with azathioprine initially and then shifted to mycophenolate mofetil, and 1 patient it was started with azathioprine and then shifted to methotrexate. So, the indication for cyclophosphamide being treatment failure to other immunosuppressants was found in 6 cases, and 1 patient developed uncontrolled diabetes mellitus, and hence he was shifted to cyclophosphamide due to steroid intolerance, and 1 case had elevated liver enzymes due to methotrexate, and hence was shifted to cyclophosphamide. So, the ocular findings, 50% of the cases had vitritis, 50% of the cases had anterioritis during the course of study, and 10 eyes showed sunset glow fundus, and 2 eyes had optic disc edema. The ocular complications, 37% of the cases had cataract, and 27% of the cases had choroidal neovascular membrane, 18% of the cases had glaucoma and ocular hypertension each. As for the systemic side effects, only 1 patient had a urinary tract infection that was transient. So, as for the recurrences, 5 cases had a single episode of recurrence, and 1 case had 2 episodes of recurrence, and recurrence was in the form of anterior uveitis. So, we found that we had a statistically significant visual acuity improvement with a p-value of 0.017 with cyclophosphamide therapy, and all patients achieved control of inflammation at the end of the study period. So, here we see a patient with resolved bilateral exudative retinal detachment with optic disc edema, a fluorescent angiography showing pinpoint hyperfluorescence. So, as for the discussion, VKH recurrences had anterior uveitis with more inflammation, and hence aggressive therapy is required. Murthy et al. Stated that cyclophosphamide, a single IV infusion for 22% of his cases. In our study, we used only oral cyclophosphamide, and Pujar et al. Stated that 81.3% of his cases had control of inflammation with cyclophosphamide, In our cases, all our patients had control of inflammation with cyclophosphamide. So, as for systemic side effects, Pujaretal stated that leukopenia was seen in 18% of his cases, and hematuria was seen in 7% of the cases. In our case, we had only one patient with urinary tract infection that was for a transient, and a careful lab monitoring. Hence, we mandate that a careful lab monitoring is required for every 2 months during the follow-up period. And it is important to weigh the risk and benefits before initiation of therapy. The results suggest that cyclophosphamide is an effective treatment modality in controlling the inflammation and improving the visual acuity in refractory cases of VKH. The indication being high risk of vision loss, and other treatment modalities have failed. Our limitations are, it's a retrospective, non-randomized, short-term, single-center study, and there has been variations in the previously used immunosuppressive agents. Hence, a prospective randomized long-term study is required to decide on the therapy. Thank you.
At what duration of disease will you call it failure? 3 months, 2 months, 1 month, 1 year? When would you call a failure of immunosuppression?
Sir, when the response is not there for a period of 2 months, even with the maximal steroid therapy, then we call it failure.
First line is steroids with immunosuppressive or without immunosuppressive?
We go ahead with the immunosuppressive agents.
So at 2 months, if high dose steroids, full dose, do not give a response.
When they're not giving a response, then we have to think over.
But immunosuppressive will take 3 months to act. So you will not taper the steroid for 2 months?
Like we have to start it with a high dose steroid, sir, and if it's...
If I start with 1 milligram steroid,
yes,
when
sir.
do I taper? What is your indication for tapering steroids?
The indication when the inflammatory control, we find the cells...
So you give full dose for 2 months, 60 kg patient will give 60 milligram for 2 months?
Steroids, we don't give it that way, sir.
So failure would be at 1 month or 2 months?
2 months.
2 months. So you'll give full dose and you will start when will you start the immunosuppressive?
So we start the immunosuppressive
from day 1.
From the first.
With steroids.
With steroids we start.
So with steroids at 2 months, if you still have disease, you will give cyclophosphamide.
When they don't respond after 2 months, then we have to think over giving cyclophosphamide.
2 months of full dose steroids and with immunosuppressive.
Yes, sir. With steroid and immunosuppressive.
Just a comment. It's a nice study. My experience is also the same. I call cyclophosphamide as the Brahmastra to the patient because it is the last resort of the immunosuppressive treatment in case of VKH or uveitis. But one need to be very cautious about that. The reason is that it brings down the leukocyte count so fast that indicates its acting actually. And you should not give that patient who was not going to come back and will go on taking the medicine. That you should be very careful about cyclophosphamide.